industries in the world demand as much scrutiny and regulation as pharmaceuticals. In medicine, quality is non-negotiable.
The World Health Organization.
Since 1948, the United Nations body, the World Health Organization, has been the foremost authority on pharmaceutical standards around the globe. Only companies who successfully pass their rigorous inspection process are awarded the World Health Organization pre-qualification standard. This seal of approval ensures customers that a brand of medicine meets the strictest safety and quality control standards in the world. Of 900 pharmaceutical companies, Getz Pharma is the only organization to have received this certification. Our facilities are equipped with state-of-the-art machinery explicitly designed to prevent cross-contamination by using continuous environmental monitoring. All our raw materials are procured solely from WHO or US FDA validated suppliers and are carefully audited before they are declared compliant. Our quality control laboratories and product testing departments remain at the forefront of our manufacturing process. A series of stability testing procedures allow us to guarantee that our medicines maintain their quality long after they've been delivered to pharmacy shelves. We have taken great care to simulate environmental conditions to ensure that medicines retain their efficacy and longevity in our particular climate. In accordance with WHO guidelines, our employees are highly qualified and regularly receive training in Europe and Japan, keeping us at the cutting edge of rapid advances in pharmaceutical research. Our quality guarantee makes us the only pharmaceutical company which can sell medicine to global bodies such as UNICEF and that are approved for sale by international markets. Today, Getz Pharma is the single largest exporter of pharmaceutical products. But more importantly, our WHO certification means that doctors and patients have access to the best quality medicines in the world at affordable prices. At Getz Pharma, we are proud of this achievement. We believe that our people deserve the same access to quality medicines and medical care the world over. Because where you live should not decide if you live.
Good morning, everyone. It's a great pleasure for us to have you all here for today's webinar, organized by Getz Pharma, collaboration with Gampaha Clinical Society. For today's webinar, it's a great honor for us to have our eminent speaker, Dr. Bodhika Samarasekera, Consultant Respiratory Physician, District General Hospital, Gampaha, President of Gampaha Clinical Society. Dr. Bodhika Samarasekera graduated from Faculty of Medical Science, University of Sri Jayawardhanapura. Doctor has undergone series of training locally and internationally. Local training, National Hospital for Respiratory Diseases, Velisara. Foreign training, Heart of England, NHS Trust, Birmingham, United Kingdom. Dr. Bodhika Samarasekera was the Secretary of Sri Lanka College of Pulmonologists 2019 and 2020, and also 2017 and 2018. And Dr. Bodhika Samarasekera was the Treasurer of Sri Lanka College of Pulmonologists in 2018 and 2019. Sir, it's a great honor for us to have you here for today's webinar despite of all your busy schedule. Dear participants, if you have any questions, you can type it on Q&A or chat box. Sir, over to you to conduct the today's webinar.
Good morning, everybody. Thank you very much for that kind introduction and organizing this webinar on behalf of the Clinical Society Gampaha. I would like to thank Getz Pharma for initiating this webinar. The purpose of this is we have several guidelines and it is very many pages. So we want to summarize and improve the knowledge of medical officers to best give the best care for our COVID patients in this critical situation. So let's see the current situation in Sri Lanka. We have total and active cases, total confirmed is around 180,000, active cases 32,000, daily new cases around, we are going at 2,800. And so we have 1,363 deaths. So now we are in a bit of a critical stage. So age distribution, it is apparent in even younger ages. And we have, even though little bit daily cases are a little reduced, but the PCR testing also a little bit reduced. So, but there is a big concern about the disease spread here. So COVID-19 is an emerging, rapidly evolving situation. If you take a patient, like patients, asymptomatic or mildly symptomatic patients, whether they are previously healthy or chronic lung disease or chronic other diseases, most of patients are recovering, but some patients around the 8th day, like second week, at the beginning of the second week, they develop dyspnea and pulmonary infiltrates. And later on, they may go into acute respiratory distress syndrome and leading into death in few patients. So this is a serious concern. And around 5 days, we get symptoms, and second week, we start the complications. So early assessing of the severity is very important. The pulse oximeter is playing a big role here. The saturation, monitoring saturation is very important. We are talking that about keeping asymptomatic patients at home, but all these patients should be monitored very closely because hypoxia is apparent in a certain group of patients, and around 5% of patients are critically ill. So not only the saturation, you have to assess their respiratory distress by assessing whether using necessary muscles and respiratory rate and so on. I just brief on the clinical severity criteria. Mild illness, it is called individuals who have any of various signs and symptoms of COVID-19, example, fever, cough, sore throat, malaise, headache, and muscle pain, but without shortness of breath, dyspnea, or abnormal chest imaging. And moderate illness is individuals who have evidence of lower respiratory disease by clinical assessment or imaging, and at a saturation of more than, still saturation is more than 94% on room air at sea level. Severe illness, individuals who have individuals who have respiratory frequency more than 30 breaths per minute and saturation less than 94 on room air at sea level. For patients of chronic hypoxemia, there is a decrease from baseline more than 3%. And we have to assess the PaO to FiO2 ratio if it is less than 300, and lung infiltrates more than 50%. It is in the severe category. Critical illness, individuals who have respiratory failure, septic shock, or multi-organ dysfunction. So first, if a patient is in the hospital, we have to do some basic laboratory workup, like full blood count. They usually show leukopenia, lymphopenia, and thrombocytopenia. Lymphopenia is very important. It's a bad prognosis sign. And CRP is also increased. And procalcitonin sometimes helps to increase, which is increased in secondary bacterial pneumonia, and help to exclude that for certain interventions, especially. And D-dimers, serum LDH, serum ferritin, creatine kinase, and CPK are indicators of bad poor prognosis, and also D-dimers helpful to diagnose assess patients suspecting pulmonary embolism. So imaging is important in these patients. So this is one of our patients. Most of the patients who are hypoxic show some CT or chest X-ray changes. This is one of severely ill patients who presented with low saturation, and you can appreciate there are peripheral consolidations bilaterally and subpleural consolidations. So, and this again, this patient also chest X-ray shows peripheral consolidation, which is a characteristic feature of COVID pneumonia. And this patient also, if you can appreciate, there's a pneumothorax, got a pneumothorax as well. Again, another patient, so shows bilateral lows on consolidation. Lows on consolidations are prominent in this disease, and as well as peripheral. So if you don't have a chest X-ray abruptly, like, you can, if you ultrasound scan, you can assess the patient, the severe patients, like they show few ultrasound signs like these increased B lines. This is called light beam signs, confluent increase of B lines in one of COVID diagnosed patients with severe pneumonia, and they can show peripheral consolidation, and their pleural lines are not regular. The regular pleural lines and the breaking down of pleural lines are one of the feature of ultrasound feature of COVID pneumonia. And imaging, if you have facilities, like better to go for HRCT for if you are going for interventions like this HRCT shows again bilateral consolidation, is subpleural consolidation and ground glass patches. So imaging also very important in these patients. So COVID-19 disease has a two process. Early phase is like driven by replication of the SARS-CoV-2 virus, and late phase driven by an exaggerated immune inflammatory response to the virus that lead to tissue damage. So this first phase, like antiviral therapies, have a role, and second phase, immunomodulatory therapies have a role. In COVID-19 infection, there are many inflammatory signals, cytokines involved, many dendritic cells, monocyte and macrophage. Together, they will produce a cytokine storm, which outcome is the acute respiratory distress syndrome and multi-organ failure, inflammation syndrome, and death also can occur. So it is important to have idea of various action of the cytokines and inflammatory pathways. So when coronavirus attach to the ACE2 receptor, then they will activate many inflammatory pathways leading to cytokine storm, and interleukin 6 and other interleukins play a big role. And these pathways, there's importance of management as well. So disease severity based approach is very important to assess, like NIH guidelines, like the patients are categorized into 5 categories. First group is patients who are not hospitalized, mild to moderate COVID-19. And second group is hospitalized but does not require supplemental oxygen. Third group is hospitalized and requires supplemental oxygen. But this group, they don't require oxygen delivery through a high flow device or a non-invasive ventilator or invasive mechanical ventilator or ECMO. And hospitalized patients, the fourth group is hospitalized patients that requires oxygen delivery through a high flow device or non-invasive ventilation. And the fourth group is hospitalized patients that requires invasive mechanical ventilation or ECMO. So how do you manage hospitalized patients but doesn't require oxygen? This is called moderate disease. This group not recommend to start dexamethasone unless they are hypoxic, and outcome will be worse at this stage if you start dexamethasone in non-hypoxic patients. Antibiotics are not recommended unless evidence of secondary bacterial infections such as lung signs, chest X-ray changes, increased inflammatory markers, so on. Remdesivir may be beneficial in this group. These patients, the recommendation of many guidelines say consider all hospitalized patients prophylactic anticoagulation, but you have to assess the risk factors and contraindications such as renal failure and so on. ERS recommendation is strong for this group, but evidence are low. Example is enoxaparin 40 milligrams subcut. And hospitalized patient who doesn't require oxygen, continuing, vitamin D may be beneficial in this group. There are some studies with severely, some patients of this vitamin D deficiency is there. Vitamin C, there are insufficient data to recommend either for or against in non-critical ill patients, but we are using as supplementary therapies in most of our setting. Zinc should not be used above dietary allowance. So 8 milligram per day for women or 11 milligram per day for men. Hydroxychloroquine, there's no evidence to use that, increased side effects and strong recommendations against to use it. Then we'll go for the next group, hospitalized patients who require oxygen. There's saturation less than 94 on room air and who are on low flow oxygen. These patients, oxygen should be given via face mask or venturi mask or NRBM. and the targeted saturation is 92 to 96, but COPD patients you target around 88 to 92. So these patients are the patients who need dexamethasone, IV or per oral, 60 milligrams daily for 10 days or until discharge, whichever comes first. And anticoagulation of these patients is essential. Prophylactic dose of enoxaparin, 40 milligrams subcut. But if clinically suspect pulmonary embolism, go ahead for CTPA. If there is no facilities, then at least try to do a D-dimer. If CTPA evidence or clinical suspicions or D-dimer is more than 1,500, start treatment dose of enoxaparin, 1.5 milligram per kg once daily or 1 milligram per kg twice daily. And antibiotics, if secondary bacterial infection is suspected, usually also start antibiotics, start ceftriaxone IV daily or cefotaxime 1 gram 8 hourly. So early microbiological advice is essential here. And later on, like if the CRP is rising and clinically not improving, we are going higher level of antibiotics like meropenem or piperacillin tazobactam with the with liaison with collaboration with the microbiological team. So this is the recovery trial data. If you appreciate this graph, like when using dexamethasone, there is a 28-day mortality benefit all participants of the recovery trial. So mortality is reduced in these patients who are on dexamethasone. And the group B is patients who are on invasive mechanical ventilation. They have more benefit at 28 days. You can appreciate here. Mortality is markedly reduced on these patients on this study. And oxygen only, also there is a reduction of mortality in dexamethasone groups than usual care. But patients who are not receiving oxygen, the usual care is the mortality reduced in usual care than the dexamethasone. So this outcome is worse in dexamethasone in this group. So the vitamin D levels, when considering the severely, if you can appreciate these two charts, like mild to moderate patients, that vitamin D deficiency is around 30%, but in severely ill patients, they have a very high group of patients are having percentage of having vitamin D deficiency around 61 to 96. So respiratory support also important in these patients. First, we start with low flow supplemental oxygen. We give via face mask or venturi mask or non-breathing mask. Pediatric patients can use nasal cannula. Again, aim is to keep the saturation more than 92 to 96, and COPD patients 88 to 92. If failing or any respiratory distress, step up to high flow oxygen or non-invasive ventilation is essential without any delay, because delay can cause many problems. This is the group of color coded venturi mask. You can use different percentages of venturi mask, and also you have to have idea of NRBM mask, very essential, especially when we are transferring our patients to another center. So high flow nasal oxygen therapy is the next step if you are failing of low flow oxygen. So there is a device called high flow oxygen cannula therapy system. This has a flow meter and air oxygen blender, and there is a humidifier and which delivers heated air in the inspiratory circuit via a nasal cannula. At the moment, we are using around 5-6 nasal cannulas for patients in our wards. So flow rate and FiO2 is important. We usually commence with low flow rate, start with 15 to 30 liters per minute, and we escalate gradually up to 40 to 60 liters per minute. And it is important to check hospital capacity of oxygen, which we can deliver intermittent high flow oxygen, because high amount of oxygen is utilized in high flow nasal oxygen therapy. So always check the hospital oxygen capacity. And here again, the saturation target is 92 to 96. COPD patients 88 to 92. So weaning off also, we first wean the FiO2 up to 0.4, then the flow 5 liters per minute. And patients on NIV can be given high flow intermittently because in NIV, when there are patients who are eating or drinking, like you can shift them to high flow nasal cannula. If target not achieved, quickly escalation, discuss with the intensivist and the anesthetist for escalation to the ICU for ventilation of these patients. And non-invasive ventilation has a very old history, and but it is also important. It can be used in these patients for respiratory support of these COVID patients. NIV has a very long history. They started as iron lung, were used in World War II and earlier in the Spanish flu epidemic as well. There are two ways of giving NIV. One is the continuous CPAP and continuous positive airway pressure, and the second one is the BIPAP, bi-level positive airway pressure. Continuous positive airway pressure can be start with 7 to 10 centimeters H2O, and for CPAP machines with single circuit use, we have to use viral filters with non-vented mask with exhalation ports, because all high flow and CPAP and BiPAP all has a high risk of aerosol generation. So for the protection, we have to use viral filters and non-vented masks. But it's better if you have dual circuits can be used with non-vented mask and viral filters. And viral filters should be placed between the mask and the exhalation port. Again, target to achieve saturation of 92 to 96 for these patients. Failing that, you have to again escalate these patients to a high level of care after discussing with anesthetists and intensivists. So this is the continuous positive air pressure. Your inspiration and expiration, you give the same level of pressure on CPAP through a CPAP machine. And NIV, non-invasive ventilation, I told that there are two groups like CPAP and bi-level. So bi-level also can be delivered with non-vented mask and dual limb breathing circuits. There's the best way to maintain FiO2 also. If NIV delivered with a single tube, again, you have to use a viral filter between the mask and the exhalation port. Choose NIV setting according to the patient's clinical condition. IPAP is called inspiratory positive airway pressure. EPAP is called expiratory positive airway pressure. So inspiratory positive air pressure is usually at high, we keep at high level, and EPAP is equal to PEEP. The difference between IPAP and EPAP is equal to pressure support. So BiPAP is also using as a respiratory support for these patients. So, and the positioning of patients is improved, very important. Awake-prone positioning, you have to educate all the patients to change their positions frequent hours, like every 1 hour or 2 hours, and this may improve the VQ mismatch and may improve the oxygenation and may improve the work of breathing, and this can be combined even with high flow nasal oxygen and NIV. So Tocilizumab is a interleukin 6 receptor antibodies we use for certain group of patients with different success. This Tocilizumab and Sarilumab had been studied in many centers, and this is the interleukin 6 receptor. So this is Tocilizumab and Sarilumab are receptor antibodies. So what are the indications? Tocilizumab, the decision should be taken by MDT, respiratory physician or intensivist or anesthetist, and dose is 8 milligram per kg, maximum 800 milligrams in 100 milliliters normal saline over 1 hour. What are the inclusion criteria is also using as a respiratory support for these patients. So, and the positioning of patients is improved, very important. Awake-prone positioning, you have to educate all the patients to change their positions frequent hours, like every 1 hour or 2 hours, and this may improve the VQ mismatch and may improve the oxygenation and may improve the work of breathing, and this can be combined even with high flow nasal oxygen and NIV. So Tocilizumab is a interleukin 6 receptor antibody. antibodies we use for certain group of patients with different success. Uh, this Tocilizumab and Sarilumab has had been studied in many centers, and this is the interleukin 6 receptor. So this is Tocilizumab and Sarilumab are receptor antibodies. So what are the indications? Tocilizumab, the decision should be taken by MDT, respiratory physician or intensivist or anesthetist, and dose is 8 milligram per kg, maximum 800 milligrams in 100 milliliters normal saline over 1 hour. So inclusion criteria should have either completed or currently on steroids. So all the patients should be on either dexamethasone, steroid like dexamethasone. If dexamethasone is not suitable, we can use prednisolone 40 milligram or methylprednisolone 32 milligrams equivalent doses. So patients should be on steroid, and patients are hypoxemic or and require high flow nasal oxygen with FiO2 more than 0.4, 30 liters per minute, flow rate of 30 liters per minute, or they are on non-invasive ventilation or mechanical ventilation with rapidly increased supplemental oxygen demand, and worsening chest X-ray signs like HRCT, chest X-ray, HRCT, or ultrasound chest images like worsening changes, and CRP should be more than 75 milligram per deciliter, or CRP should be doubled within 24 hours, and need to exclude bacterial or viral infections other than SARS-CoV-2 infection. And procalcitonin here plays a big role to exclude secondary bacterial infections. What are the contraindications for using tocilizumab? Liver enzyme alt more than 5 times, platelet less than 50,000, severe neutropenia less than 500, and you have active disease of TB or herpes zoster. The patient is septic, GI perforation, and multiple sclerosis. These are the contraindications to use tocilizumab, and this is they have shown the probability of survival improved with tocilizumab and sarilumab compared with the control, and also probability of discharge from the ICU also improved. In summary of the management, so there are strong recommendation and there are conditional recommendation. This is the ERS slide. So all the patients should be on supportive care, and patients who are not requiring oxygen, they should be on anticoagulation. Hospitalized patients should be on anticoagulation and supportive care. Patients who are requiring supplemental oxygen, again, they should be on anticoagulation, the prophylaxis or a treatment, and they should be on corticosteroids such as dexamethasone, or prednisolone, or methylprednisolone. We can try anti-IL-6 therapies, tocilizumab, sarilumab, for these patients, but there are conditional recommendations with mixed benefits. And patients who are requiring NIV support with high flow nasal oxygen or a CPAP, again, they should be given supportive care, anticoagulation, corticosteroid, and anti-IL-6 therapy. Receptor blockers are a conditional recommendation. Is it important to detection the hypoxia early? This is a very important concept now talking these days. Early detection of hypoxia can we prevent the progression of severe lung disease. So saturation monitored after exertion, some recommendations, international recommendations, 40 steps walk or sit-ups for 1 minute, and monitor saturation for about 1 to 2 minutes. If exercise-induced saturation is less than 95%, then is it worth to for early intervention, the triple therapy of dexamethasone, enoxaparin, and antibiotics when indicated. So these are the triple therapies, and the triple measures like oxygen, rest, and positioning, including prone positioning. So these early interventions, whether they can prevent the progression of the disease. So my colleague, Dr. Mahendra Ekanayake, consultant physician at who is looking after Vathara and Pomagam hospitals, described this modified exertional desaturation test. I also experienced. I went to Vathar Hospital and spend few hours there and observe all the patients, and they are managing the patients very nicely, with this simple test, and they with very few oxygen cylinders, like they have only 8 cylinders at Vathar, and most of patients discharged without problem with early triple and triple therapy and the triple measures. So modified desaturation test. This is Dr. Mahendra's slides as well. Uh, Two ways of doing is this 8 to 10 times sit to stand on a chair or 40-step walk test. So walking up to the bed or toilet and return to the pulse oximeter. This is a simple and measure saturation while on routine activity and with minimal exertion, can reproduce at any resource poor setting. So what is the objective of this? These are slides from Dr. Mahendra Ekanayake again. To detect COVID pneumonia with early exertional desaturation, silent pneumonia with early exertional desaturation, speed test as early as possible. Even before they show drop of saturation below the normal level, and before developing signs and symptoms of increased work of breathing. When saturation drops below 95% and no signs of increased work of breathing, it is called COVID pneumonia with silent hypoxia. Next progression would be COVID pneumonia with a drop of saturation and established ARDS. Are we going to? It is always necessary to stop and stop going to this step. How to do in resource poor settings, again, is Dr. Mahendra's slides. So step one, you put a pulse oximeter on finger and sit and rest for about 1 minute and ensure the good wave. These should not be done with actually with the finger pulse oximeter. You get a good monitor and monitor the pulse wave, ensure good waveform, and document the baseline saturation. Then step two is stand and sit for 8 to 10 times. If there's no contraindication, I will tell you later. So patients stand and sit for 8 to 10 times. And step three is observe the pulse oximeter. So we should not just put the pulse oximeter and take it off like 30 seconds. We have to continuously observe for about 1 to 2 minutes. So that is very important in this test. So contraindication not done in if resting saturation below 96, if they have chest pain, recent MI or chest pain, and shortness of breath at rest, physical ailment, and patient's compliance, and observe the competency of the patients. So this is one of Dr. Mahendra's patients. I asked for his slides. This is a case of 31-year-old patient, asymptomatic and no symptoms at rest. I had history of fever for 2 days and had other constitutional symptoms, no signs of increased work of breathing, and additional saturation, so admission saturation to home agama was 100 on room air. So this is his chart. So you can appreciate that for 13th, it is 100%, 14th again 100%, evening it's 98. They are doing it regularly for Magama and also Vathara. 15th again 98, 15th morning 99, and but the desaturation test done on 15th, that saturation was 95. So again 98, 98, 99 after they intervened, they started triple therapy. And this is the X-ray of the HRCT of these patients, which shows ground glass, peripheral subpleural ground glass. So the report comes as HRCT appearance, are early changes for pneumonia. So this is the patient's D dimer levels more than 5,000. So isn't that important to detect these patients very early and early intervention, and patient recovered uneventfully with simple triple treatment and triple measures. So we do not want to diagnose COVID pneumonia late. No in fighting in red zone where patients with severe ARDS. We have experienced that when the patients comes late with severe pneumonias, there's chance is less. So mortality is very high and more resource needed, more manpower needed and cannot win this battle by increasing the number of ICU beds alone. So ARDS. So I can try to get a video of that.
Dr. pulse oximeter දාගන්න වම් අතට හරි දැන් හිටගෙන වාඩි වෙන්න 8 සැරයක් 1යි 2යි 3යි 4යි 5යි 6යි 7යි 8යි දැන් වාඩි වෙලා හොම පල්ස් ඔක්සිමීටරේ දාගෙන ඉන්න.
So other important thing is that's how they did the saturation, modified desaturation test. And other important test is important thing is transferring patients for treatment centers. We noticed like patients being transferred without adequate oxygen while on that while traveling on the in the ambulance. There are problems with emptying the oxygen cylinders, and we have to ensure that there is adequate oxygen cylinders before transferring patients, adequate mask, NRBM, and also staff protection like PPE. So once like we have experienced one of our house officers, like while transferring, she developed vomiting and she had to remove the PPE, and there were no other PPEs in the ambulance. So those are the mistakes. So you have to learn from mistakes. This COVID is, this situation is new to all of us. We are learning. All of us are learning. So it is important and ensure safe transfer of patients with all the adequate facilities when the staff is traveling, and also hypoxic patients need to be accompanied by a doctor and adequate staff members. My acknowledge. So in summary, like we have to detect all these patients early is very important rather than doing it later. And all the patients, hypoxic patients, should be on dexamethasone, triple therapy, and enoxaparin and antibiotics where appropriate. And also we should take the measures like triple measures like rest. The patients need adequate rest, and also need positioning, and also most importantly the oxygen, so, and respiratory support. So we should not forget that. And so out of all, it is very important to monitor these patients early and detect the saturation and silent hypoxia early. So my acknowledgements, Dr. Mahendra Ekanayake, consultant physician, for his slides and videos, and Dr. Amil Ratnapala, again consultant respiratory physician, and my medical officer, Dr. Tarandu Evaldenia, who also supported me in some slides. So thank you very much. And on this occasion, I would like to thank the people who dedicated to develop this respiratory high dependence unit. Now we have taken our patients yesterday, all Ministry of Health, Sri Lanka Navy, and all other donors, and my colleagues, and in all categories who worked hard to develop this unit. Thank you very much. So one question is, what is the CRP to suspect secondary infection? We can't go alone with the CRP. CRP is like high usually in these patients, around hundreds with the inflammation. But we have to clinically assess the patient, like imaging and clinical examination, assessment of the patient. Patient may having fever, and also if any suspicion, and we are going to intervene. If procalcitonin available, it is one of the best tests to assess secondary bacterial infection. So the other question is, if biochemical markers such as D-dimers high, can start dexamethasone without required oxygen. No, we are not going through the D-dimers to start oxygen. Oxygen need to start when patients are hypoxic, right? Patients, the saturation, resting saturation less than 94, or now we have new entity like the exercise, once you do modified exercise test, like exercise desaturation test, like then we can assess the saturation if it's dropping. Also, few centers we are starting dexamethasone on these patients, but not, that is, this borderline group is not in the guidelines, but I mean, there are clear benefits. That is why it is important. And there's another question of, is there a place for post-exercise saturation? Yes, as I mentioned earlier, like, 40 steps walking. After 40 steps walking, we can check the saturation of these patients. If there's a desaturation, again, there's indication to early intervention of these patients. And so what are the guidelines? This is based on the other question. There are initial management part of the ERS and NIH guidelines, but latter part, what is doing practically in few centers, we are practicing this not in the guideline, the exercise desaturation test and starting dexamethasone. So dexamethasone need to be used very carefully, only in the hypoxic patients. We use few group of exercise-induced hypoxic patients. That's the that is the rationale we described, like that early patients who were desaturated early, they had CT changes. Someone may question that without any intervention, these may disappear, but we really don't know. This disease is like, no one knows exact mechanisms and all still. So, but we experience in few centers, as Dr. Mahendra described, there is good results early in triple therapy with exercise desaturation tests. So when exactly can you start steroid? As I told early, like when the saturation is there 94, we have to start dexamethasone. So regarding inclusion criteria of tocilizumab, all the components should be there, or one is enough is the question. Tocilizumab, I mean, in Sri Lanka, the guideline committee decided like to at least, because we have the tocilizumab, the drug is cost about 100,000, as well as we have very limited stock. So as per guidelines, like we had very stringent criteria, go for very stringent criteria. So this should be multidisciplinary discussion, and there should be all the components, like patient should be hypoxic, patient should be on the steroids, and patient should CRP should be high. So one criteria alone is not enough to start tocilizumab. is remdesivir available or included in guidelines? Like remdesivir, the Sri Lanka College of Pulmonologists and I think CCP are in the process of bringing down remdesivir. So it is in the process, but at the moment, since it's not in the available, it's not in the guidelines. Thank you very much. On behalf of the Clinical Society Gampaha, I would like to thank Gets Pharma for organizing this event. To actually, the aim is to improve the knowledge of our medical officers throughout the country to act correctly, act fast, and early detection of these patients, and intervene quickly to avoid unnecessary deaths. So that is the main purpose of this lecture. I think, I'm really grateful to Gets Pharma for organizing this webinar. Thank you very much.
Thank you very much for that, conducting that very informative webinar. I'm sure it's a value addition for all of us. Thank you for all the participants who make this event a success. Thank you very much, sir, once again. Good day.